Good morning, everybody. Assalamu alaikum. Topic today is cardiovascular disease and pregnancy. We'll start with the objectives. So I'm going to talk to you about the backgrounds and the importance of cardiovascular disease and pregnancy. Then what is the normal physiology which happens during pregnancy. Then risk stratification. Then special disease group of cardiovascular disease and pregnancy. We in cardiology, we have a lot of sources for guidelines, like the American College of Cardiology, American Heart Association, also the European Society of Cardiology. In the Middle East, we can take from any. So this special topic or particular topic, it was presented well by the European Society of Cardiology. Their latest guidelines is in 2011. It's not very new. It is under the process of being updated right now. So this is the reference, if you like to go back to the reference. 0.2 up to 4% of all pregnancies in the Western countries are complicated by cardiovascular disease. And why is that? We are having increasing prevalence of cardiovascular risk factors: obesity, sedentary lifestyle, smoking, diabetes. So we start to see those more. We expect to see more cardiovascular disease. Increasing age at the first pregnancy. So we advocate earlier marriage. Improvement of the treatment of congenital heart disease. This is very important. We treat those who have a complex congenital heart disease and they make it into adolescence and they get married and they get pregnant and they come to us. If you look at this is a UK study. It shows the overall death of the mothers. And as you can see, let me see if I can get a pointer. Yep. The cardiac cause is the majority. Then thromboembolism, venous thromboembolism, then suicide, and etc. So cardiovascular is very important. Not only that, it is prevalent. It is increasing with time. Again, you start like in 87, it was around 10%. The causes of cardiovascular causes of death in the mother. Now, 2005, like a few years ago, it exceeds 20%. So we know now it's important. So let's see the normal physiology which happens to the pregnant lady from cardiovascular perspective. First of all, they're going to increase their plasma volume. See, the red line is the plasma volume. By 24 weeks, just a little bit past half of pregnancy, they increase their volume around 50%. And then the heart rate also starts to increase early on. As the volume increases, the heart rate increases, the cardiac output also increases. So by 20 weeks or 24 weeks, their cardiac output is again almost 50% more than the baseline. Not only that, their blood pressure will drop early in pregnancy, and by the first trimester, their blood pressure will be around 10 millimeter mercury lower than their baseline. So again, reducing afterload will increase the cardiac output. This is law in cardiology. So with all this increase in volume, in echocardiography, when we see the heart of a pregnant woman, you can see it is dilated. Up to 30% it can dilate as a normal physiology, nothing wrong with her. The other issue here is hypercoagulable status. See, due to all that pregnancy hormones, they will have concentration of coagulation factor. They will have increase in adhesiveness of platelet, and overall they will be in a hypercoagulable status. This is very important. We have to keep it in mind so we know how to treat them. They are not like anyone else. Again, in cardiology, we see a lady, pregnant lady, who is known to have a cardiovascular problem. First thing we have to do is to risk stratify this pregnant lady. We have a lot of scoring system. I will mention, just for an example, the CarPreg scoring system. We have 4 items. We give each 1 point. And if the lady is having 0 point, her risk of cardiovascular complication is 5%, knowing that she has a cardiovascular problem to start with. 1.27. More than 1 point, 75%. So just go quickly. Prior cardiac event, heart failure, TIA, stroke before the pregnancy is 1 point. Baseline, New York Heart Association function class more than 2, or cyanosis, another point. Left heart obstruction, i.e. mitral valve stenosis, aortic valve stenosis, or hypertrophic obstructive cardiomyopathy with significant gradient is another point. So any one of them. And lastly but not least is reduced systemic systolic function, less than ejection fraction less than 40%. But then now we have a more commonly used scoring system or classification system we use, which is the modified WHO classification of maternal cardiovascular risk. It is simpler. We don't need to calculate anything. We don't need to memorize anything. Just we need to know that it is classified into 4 classes. Class 1, those ladies were no detectable or increased risk of maternal mortality or morbidity. Just need to go next. Okay. So we follow them for 1 time during their pregnancy, maximum 2 times. Then we have class 2. You have a small increase in risk of maternal mortality or increased morbidity, and we follow them every trimester, yani 3-4 times during their pregnancy. Then we come into the serious class, class 3. They have increased risk of maternal mortality, severe morbidity, and they have to be followed by an expert in the field, and they should be seen monthly or every 2 months. Class 4 is those ladies who should not continue their pregnancy. We should consider termination of the pregnancy, and it is contraindicated to start with. This is why it is very important for counseling prior to pregnancy and even marriage. So if a lady is coming to you in the cardiology clinic and you are following her for years and she's getting married, you have to tell her the risk of getting pregnant. But they don't listen anyways. So who lies in class 1? Class 1 is the uncomplicated small or mild, maybe pulmonary stenosis, PDA, mitral mitral valve prolapse. And also if we have a successful repair of simple lesion, like repaired ASD, VSD, some atrial or ventricular ectopics, yani PAC, PVC, all in class 1. We see them once only during their pregnancy. Come to class 2, ASD, VSD, which is unoperated, atrial septal defect, ventricular septal defect, repaired tetralogy of Fallot, most of the arrhythmias in class 2. Then 2 to 3, it depends on the individual. If you have a mild form of ventricular impairment, hypertrophic cardiomyopathy without significant obstruction, native or tissue valve disease, Marfan syndrome. See, Marfan syndrome is very important. We'll talk about this later. But Marfan syndrome has a tendency, it's a collagen disease. So we have a tendency of aortic dilatation and dissection. So Marfan syndrome without aortic dilatation, it's class 2 to 3. If the aorta is dilated but less than 45 in a patient with bicuspid aortic valve disease, which is also associated with aortopathy, is risky. Repaired coartication, even repaired, it is risky. Remember, we have increase in the volume, decrease in the afterload, so the gradient will keep increasing. Now, the serious group, who we should see frequently, mechanical valve. Normal heart, everything is normal. Only having mechanical valve, very risk. Remember the hypercoagulable status. So the risk of thrombosis of the valve is serious. Systemic right ventricle. So those whose the right ventricle works as the systemic ventricle is at increased risk. Certain congenital disease. Fontan circulation. A word about Fontan, we call it a univentricular or the one ventricle physiology, where you have only one ventricle and the IVC, SVC connected directly to the pulmonary artery, and the only ventricle you have works as the only pump which pumps the blood to the body. Unrepaired cyanotic heart disease is in class 3. Other complex congenital heart disease and aortic dilatation in Marfan 40 to 45 is class 3. 45 to 50 in bicuspid aortic valve is also class 3. Okay, who should not get pregnant? Class 4. Pulmonary arterial hypertension of any cause. Should not get pregnant, period. Severe LV dysfunction. Ejection fraction less than 30%. No pregnancy, sorry. Previous peripartum, we see it common, the previous peripartum cardiomyopathy with any residual ventricular impairment, let's say ejection fraction 45, sorry, no pregnancy for you. Severe mitral stenosis, severe symptomatic aortic stenosis, obstruction. Any severe obstruction, keep it in mind, should not get pregnant. Get pregnant after you fix the obstruction. Marfan syndrome with aorta, dilated aorta, more than 45. No. Fix your aorta, cut your aorta, put a new one, and then get pregnant. Aortic dilatation, more than 50 is the same, and native severe coarctation. A word about each specific cardiac group. We divide them quickly like congenital, valvular heart disease, cardiomyopathy, coronary artery disease, hypertension, and venous thromboembolism. I'm going to just highlight on each quickly. In general, congenital heart disease, if there is a shunt, if it is left to right shunt, from left side to the right side. So the oxygenated blood will go to the right side. It will shunt to the right side. There is no cyanosis, no big deal. Usually low risk, maximum to moderate risk, they can tolerate. But when the opposite happens, you have a right to left. You have unoxygenated blood goes to the left side, to the systemic circulation. So you have cyanosis. So if it is not repaired, it's a moderate risk if repaired. If not repaired, mother is cyanosed, oxygen saturation less than 85, there is a fetal risk for fetal death, growth retardation, etc. And if it is associated with Eisenmenger, i.e., it starts as left to right shunt, with time there is pulmonary hypertension. Then now you have reverse shunt, it's now right to left. The risk of death is 50%. So again, no pregnancy. Obstructive congenital heart disease, high risk for pregnancy if severe. So who's the low risk in those group? So patients who undergo previous successful repair for congenital heart disease, they are at low risk. They will tolerate pregnancy well if no mechanical valve, exercise tolerance is good, and the heart function is normal. So they can proceed. Other group, disease of aorta. So during pregnancy, this is normal, all ladies. During pregnancy, the dissection susceptibility is high, not like normal. And it is due to hemodynamics, which I explained, increased volume, heart rate, the wall stress. So all that will increase the susceptibility of dissection. Not only that, hormonal change also will induce some changes of the aorta and make it more susceptible. The good news is this is only temporary. After pregnancy, there is no any residual effect on the aorta. So this is why, so dissection, if it happens, it will happen usually toward the end. 50% happens in the last trimester and 30% early postpartum period. So pregnant lady, toward the end of her pregnancy, chest pain, keep in your mind aortic dissection. Otherwise, you will miss it. So, if they like to get pregnant and to avoid such complication, in case of Marfan syndrome, if the aorta is more than 45, before pregnancy, fix it. Bicuspid aortic valve, maybe 45 to 50, fix it before pregnancy. Ehlers-Danlos type 4, normal aorta, normal size, again, fix it. Because the risk of having dissection during their pregnancy is very high. Turner syndrome, we index to body surface area, and again, this is the number, more than 27 per meter square. We fix it before pregnancy. What about mode of delivery in those with those type of disease? So you know, during vaginal delivery, there is a lot of strain. There is increase in the afterload. So the increase in wall stress. So the dissection, even in this particular situation, is even more. So we understand that if the aorta is dilated more than more than 45, go for cesarean. If it is less than 40, normal to normalish, go for vaginal, no problem. If it is in between, we will individualize the decision. Makes sense. Valvular heart disease. This is really funny. General rule, if it is stenotic, it is riskier than regurgitant. High risk of hemodynamic decompensation if moderate to severe mitral stenosis, increased heart rate, increased volume, they will not tolerate it at all. The good news, we can intervene before pregnancy, we can intervene even during pregnancy. Symptomatic aortic stenosis, high risk. Indication before pregnancy, especially for aorta. Regurgitant, they're usually tolerated well if normal ejection fraction, normal LV systolic function. Medical therapy is the recommended one, and no surgery, no intervention during pregnancy. The nice topic, oral anticoagulation with vitamin K antagonist, i.e. warfarin. So fact number one, warfarin is the safest therapy to prevent valve thrombosis and are the therapy of choice of second and third trimester. This is fact. Warfarin is the safest therapy to prevent valve thrombosis, period. Now, is it contraindicated in the first trimester? We know. Second trimester, third trimester, you give it, drug of choice. We're talking mechanical valve. What about first trimester? This contraindication issue on teratogenicity is not accurate. If the dose is less than 5 milligram, you still can give it, and it is the safest way to do it. If it is higher than 5 milligram, 5 or higher, so the risk of teratogenicity is higher, then you try to avoid it. And this is in the guidelines. Okay, if you will not give warfarin, what you will do? This is important. Either you give unfractionated or low molecular weight heparin. But remember, I told you before, those pregnant ladies are not like normal people. They have hypercoagulable status. So if you're not going to strictly dose adjust their dose every week, don't do it. Find something else or find somebody to do it. Okay, even if you give enoxaparin, you give low molecular weight, you have to monitor anti-factor 10A level every week. You have to. You cannot avoid it, period. So you're pregnant, valve disease, give enoxaparin, go home, no monitoring, wrong, to court. Okay. It's funny. By 36 weeks here, oral anticoagulant should be discontinued and replaced by dose adjustment. I like to have a question here. I like to have some interaction to this scenario. Just tell me, if you have a pregnant lady, she's 36 weeks, she came in labor, she's anticoagulated with warfarin. So for the non-cardiologist, what is the mode of delivery? INR is therapeutic. Pregnant lady, she came in labor. If you say vaginal, please raise your hand. If you think vaginal, she is anticoagulated. If you think cesarean, raise your hand. So I don't know names, so don't worry, raise your hand. So who think vaginal? Anticoagulated, fully anticoagulated. If you think vaginal, raise your hand. Okay. Makes sense, yani, they are, you will not open with a knife if they are anticoagulated, صح? But it's wrong. Otherwise, I will not ask. صح? Remember that the baby or the fetus is anticoagulated, fully anticoagulated. You don't like this anticoagulated fetus to pass through the birth canal and have intracranial bleeding. So sorry, you have to cut. Okay, a word about coronary artery disease. Is it common? Not very. 3 to 6 in every 100,000 pregnancy. Atherosclerotic is among the etiology. Coronary dissection, very important. Dissection of the aorta can extend to the coronaries. So it's not always thrombosis related and should be managed invasively. Pregnant lady, STEMI, high risk non-STEMI, cath lab. Okay, so what about stable coronary artery disease? She had an MI before she liked to get pregnant. She can get pregnant if the ejection fraction is more than 40% and there is no residual ischemia. Peripartum cardiomyopathy. It's defined as new onset of LV dysfunction without other known cause. It occurs at the end of the pregnancy, towards the end of the pregnancy and following delivery. It used to be defined as the last month of pregnancy and 5 months later. So that's 6 months period. So the prevalence depends on the ethnicity, 1 in 300 up to 1 in 4,000. Etiology, uncertain. We don't know, but we know some risk factors. Multiparity, family history, ethnicity, smoking, diabetes, hypertension, preeclampsia, advanced age, and teenage. Treatment, patient delivered, she's having, or not delivered, she's having heart failure, standard anti-failure, beta blocker, Lasix. If she delivered, you may give ACE inhibitor, otherwise you find something else. Spontaneous recovery, they will recover in 50%. The risk of recurrence in the subsequent pregnancy is again 50%. Magic number, 50%. Okay, so if their ejection fraction now normalized, you treated well and she's having a normal systolic function, subsequent pregnancy or pregnancy in the future should be discouraged. You tell her, please don't get pregnant. If her ejection fraction did not normalize, the subsequent pregnancy is contraindicated. No way she has to get pregnant. I have seen ladies, they get pregnant. They don't listen, you know that. She's having 4 or 5 kids. She come to my clinic. She's having ejection fraction 30%, and now she's pregnant. Despite me telling her, please don't get pregnant. She's afraid that her husband will go and marry another lady. Yeah. So actually, I tell her husband, but even they don't listen. They like 10 kids. So I think ladies should allow, for their safety, their husband to get married to second or third. Yeah, they don't listen. Okay. Yeah. So look at this graph. Look at this graph. It's just, the yellow color is the lady who had peripartum cardiomyopathy and her ejection fraction normalized. The orange who did not normalize their ejection fraction. And you can see recurrence rate is more if they don't normalize. Symptoms more if they don't normalize. Death, see, if they don't normalize their ejection fraction in their subsequent pregnancy, they can die up to 20%. So this is serious when we tell them no pregnancy. It's very high risk compared to 0% if they normalize their ejection fraction. So again, I said etiology is uncertain. We are uncertain that it is uncertain. So there's some theories that prolactin plays a role. I think that the unbalanced oxidative stress by this product of prolactin breakdown. Now, prolactin is, the lactating hormone. It's broken down by the cathepsin D to 16 kDa prolactin. This product is not very good. Actually, it is anti-angiogenic. It's pro-inflammatory and pro-apoptotic. So we think it's bad. Can we stop prolactin? Yeah, we can try. We give bromocriptine. But remember, if you give a lady who just delivered bromocriptine, you know what will happen? No more lactation. Khalas. Go and buy expensive milk. Okay. We have to test that. Actually, it was tested before, the bromocriptine. They tested in a smaller number of patients, 20. They gave 10 standard therapy alone. The other 10 they gave standard therapy plus bromocriptine. And mortality was 10% in the bromocriptine compared to 40% in standard therapy alone. Ejection fraction, the mean on follow-up from 27 to 58% compared to 36% for those who did not receive bromocriptine. But the number is small, and it was not blinded study, so it did not make it to the guidelines. So it is not in the guidelines. But there is a newer study last year, 2017. It's a double-blind, multi-center study done in Europe. And the numbers is a little bit higher, it's 60. The one who underwent randomization, 60. But they have different design. So they have randomized 32 to 1 week of bromocriptine and 31 to 8 weeks of bromocriptine. So all received bromocriptine. And then what happened? So one received bromocriptine for a week, the other group received bromocriptine for 8 weeks. And all benefited, but those who received for 8 weeks, the rate of ejection fraction more than 50 is higher. And the rate of severe LV dysfunction or LV dysfunction below 35 ejection fraction is lower. Bottom line here, because they did not compare it to placebo, overall, the outcome of this particular study is better than any prospective study for peripartum cardiomyopathy. Only 7% had ejection fraction below 35 at 6 months follow-up. So we think that bromocriptine is here to stay, and it will make it to the guidelines. Last thing, quick word about hypertension pregnancy. It is divided into pre-existing hypertension and some, because I just said that pregnant lady, their blood pressure might go down, so the dose might go down also, or even they can go throughout pregnancy without antihypertensive medication. Gestational hypertension, which will happen during pregnancy, and preeclampsia. Preeclampsia, we'll keep it for the OB people, and we'll talk about the regular hypertension. So there is no clear evidence that if we treat mild to moderate hypertension, that there is benefit. Severe hypertension, more than 170 over 110, is an emergency, and hospitalization is recommended. Drug of choice, common question. Alpha-methyl dopa is the drug of choice. You reach the highest possible dose, still uncontrolled. Think labetalol. Labetalol is good, and only labetalol. Calcium channel blocker are the drug of second choice. Nevitimine, amlodipine. ACE inhibitor, angiotensin II antagonist, all are strictly contraindicated during pregnancy. And I would like to thank you for listening. Thank you very much.